The next few minutes we'll be talking about some newer interventions, some of the advanced interventions that we can do for controlling this, the dreaded cancer pain. So that's what we will do. So if you can just look at how difficult it is for a patient to go through the journey of cancer. Basically, this is a lady with advanced endometrial cancer, where the cancer has already spread into her the pelvic bones. So she's really suffering a lot. She's morbidly obese. She can't sit down straight. Apart from being in the bed, she could do nothing, and she's quite desperate to control her pain. బాగా నొప్పి వచ్చేసింది. ఎక్కడ వస్తుంది నొప్పి? అక్కడ బాగా వన్ సైడెడ్ పెయిన్ ఇన్ హర్ లోవర్ pelvis. సో నెక్స్ట్, this is another boy 14-year-old with CRPS, and you can see the pain is not just his physical pain. It's not a cancer, but you can see what the emotion of cancer is, and it's a lot of social problem. His mother, his aunt, the whole family, almost like 4 or 5 people are sitting around him just to control his pain. So all he has got is a CRPS of his hand. The left hand, he'll keep it above. It's swollen. He was treated for various other problems. So, and that's 24/7, mind you. So it was so difficult for him to manage that kind of pain. You just have to realize once the pain is released, so he's a much different boy. All he had was the stellate ganglion block. By next day morning, the swollen arm is actually back to normal. And he was happily discharged. For the next few weeks, he was like that. He required another couple of blocks to make him better. So that CRPS can happen even with any of the diseases. So just with that background, I would say what we would be discussing briefly about the cancer epidemiology and few more things like barriers for pain, a bit of WHO pain ladder and some interventions. So if you look at it, cancer, at the time of diagnosis, already by then about a quarter of patients will have some amount of cancer pain. But as the treatment is progressing, the incidence of cancer, the prevalence of cancer is also starting to go up. So by the time the patient reaches an advanced cancer, almost 3 out of 4 people will have moderate to severe pain. And quite a lot of them would require some interventions to control that pain. As ma'am said before, almost 90% of pain can be controlled with a good medical management, but there will be a small proportion of patients who will require these complex interventions, and that's what we would be talking. And where will this cancer pain comes from? Quite a lot of it is the progression of the disease itself, a significant proportion, but then about 20% of that is due to the cancer chemotherapy. And then there will be some patients who will have the radiation-related fibrosis, mucositis, stomatitis, all these kind of problems which happen. So they also cause a lot of pains. Incidentally, like any other patient, these patients will also have non-malignant pain. Like any person who has got a back pain or a knee pain, these are also prone to that, and maybe in a bigger incidence to regular patients, because they are not so very well nourished and other problems which come along with that. So what would be the barriers? Majority of patients who come with cancer, there will be this kind of reluctance to report. First of all, the patient feels like it is the wrath of God that I am going through the cancer and I have to bear with this pain. So they don't tell people that they've got this problem. And then most of the times there is not enough facilities in the hospital to treat these patients who are in pain. So that's one problem. But then there is also a systemic problem where most of the doctors, not just in this country, across the world, this pain is not as a subject in your medical schooling at all, unfortunately. But that's the most common complaint why a patient comes to the hospital and gets all their treatments done, all their diagnosis, everything is done for that. But that's not part of our medical curriculum so far. So there is something that we have to address. And then once the doctors prescribe some medicines, there is a reluctance from the nurse, and the doctors themselves, they don't know enough about these medicines, as ma'am was explaining. Of course, there is a lot of regulation from the government side, particularly regarding opioids, and we were talking about all the other drugs which are available, the newer drugs, accessibility to those drugs. These are all various issues for getting that adequate amount of pain relief. So you have to screen the patient. Every patient who says they are in pain, they have to be screened properly and then taken forward to go through further treatments. So coming to the clinical assessment, first of all, we have to believe in that patient that they have pain. Particularly with cancer, if the patient says they've got pain, don't disregard it. And then we go through the ultimate goal of reducing cancer for all of the cancer-related pain is to improve their physical functioning. They should be able to spend their whatever time they've got left, even if they are a survivor. Our goal is to improve their function, reduce their distress, and finally, we have to improve their overall quality of life. So that's our main targets. And ma'am has already discussed about the WHO pain ladder. It's a sequential thing starting from a low intense medicines reaching up to the high intense. There are downsides of it. At least what it has done was over the last 30 years or so, it has reduced, even if it is partially, some amount of pain with these patients are suffering. At least it has given a framework. So this is the next one where the interventions are added to that, and we are talking about the interventions these days. What the recent discussion about the management of pain is, rather than using it as a step ladder approach, 3 steps, 4 steps, whatever, but then we are talking more about the trolley approach. So not every patient is going to be getting treated by a low-level medicine or maybe a morphine. Some patients require something else, maybe some emotional support, maybe some psychological support. Sometimes they require an interventional support. So sometimes they'll require some interventional support. So these kind of things, we just have to understand that, and we as doctors should be in a position to give the right kind of treatment as a package to the patient, and our goal should be to reduce their pain. So this is what is called as a trolley approach, where you have all the tools in your armamentarium, be it like medicine, psychological support, emotional support, whatever is required, or maybe an intervention, everything is there at your disposal, and you make a plan for the patient is the current way of treating patient. And that's what I kind of feel right now. So when you are trying to deliver a drug to the patient, what you should find out is what routes are available to me. Sometimes an oral route is very inappropriate for this patient who had a maxillofacial problem, and then he has got a trismus, can't open his mouth after the radiation. So it's very difficult. So we have to be well versed with all the different routes available for us. Not just intravenous, but then not always appropriate. We might have to go with the subcutaneous and all the other routes that are available. So you've got a various varieties, sublinguals and rectal, everything is available. And using all of that, we use various pharmacological approaches. Ma'am has already discussed, I'm not going to the details. And we use all of those and the routes that we were discussing. It can be intravenous, epidural, spinal, any route that we have. So we will be utilizing that route to give them that necessary pain relief. And this is a patient-controlled analgesia machine which has revolutionized, at least in hospital, pain management. So where you can set a background, you can give a bolus dose, you can set a lockout, and the maximum bolus that can be given to a patient. So various machines are available in those regards. So once these are discussed, now if the patient has got this severe pain, and if it is refractory and unrelenting, we would be looking at some of these interventions. So broadly, we're talking about the lower half of the body in the first instance. That's what we will be talking. So basically, there you have a celiac plexus and splanchnic block, and a little down we have a superior hypogastric, inferior, and then further down you've got the ganglion of Impar. And we'll just go through in a little bit of with a little bit of interest. So essentially what you are seeing is here, this is an anatomy of the autonomic nervous system. What you have on the aorta near the celiac axis, just above that you've got the celiac ganglia. Okay, so once the celiac ganglia, it gets its feeders, it is coming from the preganglionic structures, which are the splanchnic nerves. So you've got the greater, lesser and the least splanchnic nerves, which are coming from the top. So they are feeding into it. So they actually control most of the pain, roughly say above the umbilicus. So we are actually, that becomes our target. But then this is the lumbar sympathetic chain that we are seeing. That is the next one. You've got the sacral promontory. Just opposite that you have the superior hypogastric. Little bit below is the inferior hypogastric, and further down is the ganglion of Impar. So these are one of the main autonomic supply to your viscera, abdominal viscera, so to say. So you've got a patient in prone position, you get the needles into the right place, and most of the times you can give it behind the aorta, or you can pass through the aorta in front, and then you deliver your neurolytic substance after giving some local anesthetic as a test block. So I generally don't prefer, particularly if the patient is advanced, I don't prefer to give a neurolytic, to give a test block before, and I do it on the table itself. So I do it, find out from the patient if it is the lidocaine. Within 1 to 2 minutes, they'll get a pain relief, and then I'll proceed with the alcohol neurolysis of this patient. So this is the celiac plexus neurolysis with an alcohol. So this is the splanchnic nerves. As I was talking to you earlier, when you have your celiac plexus here, you've got your nerves which are coming from the top. So these are the greater, lesser and the least splanchnic nerves which are sitting here. So these are our next immediate targets. So this is above the crus of the diaphragm. So they're just sitting above the diaphragm. Generally, the splanchnic blocks these days, they are supposedly having less complications, less side effects compared to a celiac block. So usually we go, but then when we are going, either you can do an alcohol neurolysis, or you could also do an ablation. You can do both of them. One or the other, you can do one or the other. So when you are doing this splanchnic. So between these two, they control most of the pain which is going into the abdomen, upper abdomen at least. As I was talking to you, if this is the sacral promontory, you've got the superior hypogastric plexus which is coming here. This is the rectum, and then you've got it on either side. So very close to the great vessels. So as they're going down, so you identify them. You get the patient into generally in prone position. For reaching this, I can go through the disc, the transdiscal procedure between L5 and S1, or you can go one from either side. So you can reach to the front of the sacral promontory and do it. And there is also another way where you can approach it through an ultrasound guidance. You can go from the front, particularly if the patient is skinny, you can actually go through the front, but then you might sometimes go through the bowel. So these are 3 different routes that are available. So this is the superior hypogastric plexus. This is the ultrasound guided approach under the umbilicus, where you are identifying the top part here. So this is the L5S1 area, and then you go and deliver the drug over there. And that's the inferior hypogastric. When you are looking at the inferior hypogastric, it is present in front of the sacrum, into the hollow of the sacrum which is there. It is present in front of the sacrum. If this is the sacrum here, if you are able to appreciate it. So we are coming through the S2 foramen, align it through and through. We pass through one side to the other side. We are reaching here, put some contrast here. You can see on the AP view, it is going along the nerve roots. You are in front of the sacrum, and that's how you block the inferior hypogastric. So if you are looking at here, you probably will be able to appreciate. So these are the plexus. This is how you will be traveling from behind to the front and then treat it there. And finally, in the sympathetic chain, the last part, this is the only ganglia which is not paired. It is present in the sacral promontory. So basically, you are coming here. So that's the sacrum with a bowel shadow here. So we are coming through the sacrococcygeal junction. There are multiple ways you can go through the sacrococcygeal joint, or you can come from either side to the front and then do it. So this is the sacrococcygeal junction, and then you do the ganglion of Impar. Put some contrast here. Nicely, if you can see the sacrum, sacrococcyx, and then the needle coming here. The nice spread of the contrast before you put the drug. So basically, when you are trying to block the autonomic nervous system, those were the different ways of doing it. Of course, there is a stellate, will come later on. But then when the patient has got, this is a lady who had a stage 4 breast CA, and then quite a lot of fibrosis which is present for her. She can't even move her neck. She can't even lie down. She can't go prone. But then she was suffering terribly with her pain. So she has got pain all around this area. So completely, she just can't move her arm at all. So what more? I mean, we tried everything with her medical management. When nothing works, what we tried to do was, so we entered here from her epidural space, and then gradually thread the catheter like what Dr. Nagendra was suggesting, but we were only using a catheter. So we got into the right place there, and once we reached, so we're getting supply, the spread of the contrast all along into the cervical region. So once we got it nicely onto one side, so only the area where she has got pain, and then we started her on infusion device, and it worked really wonders. So we could relieve her pain completely. So she was fine until her final days. So similarly, this is another epidural catheterization. This was done at Basavatarkam before. So this guy had a hepatocellular carcinoma, metastatic, and even he had lung mets. So, but then it was not painful, but most of it is in the abdominal. Already done he had his celiac plexus blocks, everything was tried. So nothing was helping him. Very demanding person. He was one of the what do you call, the road town planning director or someone he is. So basically we did a thoracic or maybe thoracolumbar epidural, and then we got an excellent coverage for him, and until his last days he just lived on it, and he wouldn't allow even for a minute to take off the catheter, because we're not giving any opioids for him. So his quality of life was much better. So this is another guy who was again I actually treated him at Basavatarkam, where I came initially for this man actually to Indo-American. He was on his 4 legs. When I entered into the room, he was on his 4 legs. He had an Ewing's tumor into his bowel, into his abdomen. Already had 3 or 4 surgeries, and then it was burning pain in the pelvis. He was trying to offload the pelvis standing on his 4 legs. So literally he was trying to do that, and almost screaming in pain. So essentially what we did was took him to the operation theater. We put a catheter for him, and instantly he had a pain relief. Next day morning I went to see him. He was actually ready to go home. He was actually standing with a bag on him, and then he was ready to go home. So it was so remarkable for him, and he had it for about 5 to 6 weeks like that. And we were refilling the bag or maybe changing the bag every now and then, and it really worked. So from there on, after about 6 weeks, we had to change it.
Hello, నాకు పినల్ క్యాన్సర్ ఉందండి. ఈ ట్రీట్మెంట్ తీసుకుంటే డాక్టర్ కన్నపల్లి కృష్ణ కిరణ్ ఇక్కడ డాక్టర్ గారు రిఫర్ చేశారు. చేసాక పెయిన్ చాలా రిలీఫ్ ఉంది. ఇంతకుముందు నేను స్ట్రెచర్ మీద తిరిగేది, తర్వాత వీల్ చైర్ మీద తిరిగేది. ఇప్పుడు హ్యాపీగా ఉంది ట్రీట్మెంట్ తీసుకోవడం వల్ల.
Basically, he came in a wheelchair up into my clinic, but then post procedure he was able to walk around. For his final days, I mean, it was a terrible cancer what he had was, but it really worked for him. So this is another guy who had a large malignant sacral tumor, very big in size. This is him after 2 or 3 operations. It's still coming back, very aggressive tumor. It already affected his sciatic nerve on both sides. Primarily on one side, he can't move his leg. So he's getting very cachectic, severe pain. So what would he do? So basically, we tried everything initially, what we could, with all medical management and everything. This is one of the first cases I did when I came to the country. So yeah, we were very poor, Care Hospital, they supported me very well. We actually did it for free of cost for him. The hospital actually bore all the expenses for him. So what we did was an intrathecal catheter for him. Initially we did an intrathecal catheter, we did an epidural, didn't work well. Then we did an intrathecal catheter, and slowly what I did was put alcohol and neurolysis, because he had weakness on one side already, losing his bowel and bladder prop. There's no control. So basically when we did that, he had near complete pain relief. He was so happy after that. So it just lasted, and actually for some time he even came to that the palliative unit near Ramdev Kamudini palliative care. He was admitted for a short while with ma'am also. So he was there, and then finally he passed away. క్యాన్సర్తో బాధపడే వాళ్ళు క్యాన్సర్ నొప్పితో బాధపడాల్సిన అవసరమే లేదు. ఇవాళ జరుగుతున్న మెడికల్ అడ్వాన్సెస్ ఏవైతే ఉన్నాయో ఈ అడ్వాన్సెస్ తోటి మనము క్యాన్సర్ని దాదాపుగా సమూలంగా నిర్మూలించడానికి కావాల్సిన అన్ని రకాల మెడికల్ అడ్వాన్సెస్ కానీ సదుపాయాలు కానీ ఇప్పుడు మనకి ఇక్కడ హైదరాబాద్లో అవైలబుల్గా ఉన్నాయి. సో ఇప్పుడు ఈ క్యాన్సర్కి సంబంధించి రకరకాల మందులు, కొత్త తరహా మందులు వచ్చేసాయి. పేషెంట్కి సైడ్ ఎఫెక్ట్స్ తక్కువగా ఉండి నొప్పిని కంట్రోల్ చేసే మందులు చాలా వరకు వచ్చేసాయి. అవి తగ్గని వాళ్ళకి నెక్స్ట్ రకరకాల ఇంజెక్షన్లు, రకరకాల కెమికల్స్ తోటి నరాల్ని ఎక్కువగా ఇబ్బంది పెట్టకుండా నొప్పి తగ్గించడానికి కావాల్సిన రకరకాల ట్రీట్మెంట్లు మనకి అవైలబుల్గా ఈ రోజున మెడికల్గా వచ్చేసాయి. అంతేకాకుండా ఈ కొత్త కొత్త ఇంప్లాంట్స్, అంటే మన పేస్ మేకర్ లాంటి డివైజెస్ ఏవైతే ఉంటాయో అలాంటి పంపులు కానీ, అందులో మందులు నింపిన పంపులు కానీ, లేక ఎలక్ట్రికల్గా వాడే కొన్ని డివైజెస్ కానీ, వీటి వల్ల నరాలకి నొప్పి తెలియకుండా మనం మార్చగలిగే ఎన్నో రకాల కెపాసిటీ మన దగ్గర ఇప్పుడు బిల్డప్ చేసుకున్నాం మనము. సో ఇలాంటి ట్రీట్మెంట్స్ అన్నిటికి కూడా మనకి ఇండో బ్రిటిష్ అడ్వాన్స్ పెయిన్ క్లినిక్లో మీరు కనుక సంప్రదించినట్లయితే ఏ రకమైన ట్రీట్మెంట్ మీకు సూటబుల్ అవుతుంది అనేది అసెస్ చేసి ఈ కాంబినేషన్ ట్రీట్మెంట్ తోటి మీకు ఒక ట్రీట్మెంట్ ప్యాకేజ్ అనేది మనము తయారు చేయడానికి వీలు పడుతుంది అన్నమాట. ఇలాంటి వాటితోటి మన ఇంట్లో ఎంతో ప్రేమగా ఉండే మన పెద్దవాళ్ళు కానీ, మన ఇంట్లో ఎవరికైతే కూడా క్యాన్సర్ ఎవరికైతే వచ్చి ఉంటుందో, ఈ క్యాన్సర్ వచ్చిన వాళ్ళని వాళ్ళ చర్మాంకం ఏదైతే ఉంటుందో అది మనము నొప్పితో వాళ్ళకి ఆ బాధ కలగనివ్వకుండా వాళ్ళతోటి మనము మిగిలిన టైం ఏదైతే ఉందో చక్కగా వాళ్ళతోటి గడపడానికి మనకి ఇది ఒక సదవకాశంగా దీన్ని వినియోగించుకోవాలని నేను అందరినీ కోరుతున్నాను.